Hi everyone, this is Neel Raithatha here, consultant, audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral occluding earwax. This is their left ear, this is the worst ear out of the two. And the wax is extending all the way from the entrance of the ear canal to their eardrum. In fact, there's some wax embedded within their inferior recess, which is like a little trench just before the eardrum, which is a bit challenging to remove, and there's also some stuck on the eardrum itself as well. I've just applied some olive oil medical grade spray just to help to coagulate the wax. Laterally at least it was quite mushy. In fact, it was quite mushy in the inferior recess, which was part of the challenge to remove. And it's extremely darkened wax, which means it's been there for a while. This patient last attended about 4.5 years ago. So, and they did say that they needed to have their ears clean. They felt that they needed to have their ears clean for a while, but just haven't got around to it. So the colour of wax can help to determine its age. Freshly secreted wax is a bit more orange, and the longer the wax has been in the ear, it tends to oxidize, and it turns into a darker shade of brown and sometimes even pitch black in appearance. Now, although the wax is secreted on the outer third, when you've got an excessive buildup, some of that wax that's secreted near the entrance, it's pushed, ironically, further back into the ear canal. I would have thought initially that if you've got an excess buildup of wax, the fresher wax will push the older wax out of the ear, but actually it doesn't work that way. It tends to push the older wax deeper in the ear where it begins to solidify. And also then there's less oils and sweats deeper in the ear. So sometimes the wax can get a bit drier deep in the ear. Conversely, however, sometimes because of the increased humidity, you can find it's a bit more wet and damp. So there's no exact science, so to speak. So this wax is probably in the medial half, and there's a bit of skin around the periphery. Now, you won't see it at the moment, and we only discovered it at this patient's last appointment. They've got a small osteoma, which is a bony spur on the anterior canal wall. So I am a bit wary of that, because if you do make contact with that, it can be quite uncomfortable for the patient. So it's in my notes, and I've written exactly whereabouts it is. I said it's on the anterior canal wall. So in the case of the left ear, it's on the front part of the ear canal, and it's kind of midway into the ear canal in the pars media region. When I say pars media, you can subdivide the ear canal in many different ways. We normally work in thirds. So the outer third of the ear canal is made up of cartilage. For you guys who've been watching my channel for a while, you're aware of this already, but anyone new? So yeah, the ear canal is composed of both cartilage and bone. The outer third is made up of cartilage. The inner 2/3 is made up of bone. And you can subdivide it into a different way as well. So the outer third we can call the pars externa. The deepest, most inner third, the medial third, is called the pars interna, and the middle third we can call that the pars media. So now we're definitely in the pars interna region, and the wax at the bottom is actually within the inferior recess. As we approach the eardrum, the ear canal narrows both from the floor of the ear canal, so in essence it rises upwards, and also in the front part of the ear canal. I'm just removing this bit of skin just to get a better visual. It's partially obstructing my view, so I'm just mopping that up. So the front part of the ear canal, it protrudes inwards into the midline of the ear canal, and then it widens again, so it creates a recess anteriorly, so that's called the anterior recess. And as we approach the eardrum, the ear canal inclines upwards, and then about 0.5 centimetre away from the eardrum, it steeps back down, so it creates this little trench, basin if you like. This is where we are now, and there's some skin here which makes it a bit more difficult to suction. It's quite mushy. Now, can't embed the suction tip. You've got to be careful here. So if you embed the suction tip with too much force, you're going to be hitting the eardrum, so you want to sort of hover over it. So I'm just using the right hand side of the specula to push open the first bend. I've just put a little bit of oil in there just to help to bind and amalgamate this, and I'm just zooming in so I can get a better vision. I've also angled the specular. I've inserted it a bit higher in the ear canal, then tilted it downwards so I can actually see within the inferior recess, and I'm just hovering over. And that little hair strand doesn't help because that reduces suction power, but I can feel like I've got a good grip now, and I'm moving away really, really slowly with this wax. If I come away too quick, I lose that suction grip. So the eardrum is fully visible. Now you can see on the left hand side that white spherical object, that's the osteoma. There's a small bony growth there. There is a bit of wax surrounding that now. It looks a lot, but in retrospect, when you're comparing it to the rest of the ear canal and given the magnification of the wax gets in perspective, that's the word I was looking for, it's not actually a lot. So I'm just mopping up as much as I can safely as possible. I don't want to touch that though. And there's just a little, I'm just zooming in to see if I can get a little bit more from underneath. And I'm just going underneath. You can see how close we are to it. And I'm just hovering over because it's mushy wax. I can't apply too much pressure because we'll touch the bony part of the ear canal and also very likely then make contact with the osteoma. It doesn't need any treatment. It's not obscuring the passage of sound. Sometimes these osteomas can grow quite large and they may need to be surgically removed. But in this case, it's not causing the patient any problems. So again, I'm just hovering over this is in front of the osteoma. So, I'm happy with that. I think I'm just going to get this little bit out here. So this is kind of the trickier type of wax to remove because it's quite wet and loose. And it doesn't always just come away as you hope, but I'm happy with that. And we're just going to look at the eardrum, which is fine. And then we're going to move on to the left ear. So again, now I'm using the left-hand side of the specular. So I'm entering the ear, I'm pausing, and I'm making a side step to the left. So I'm using the left-hand side of the specular to push open that first bend to the left. Then I can just gently position the right-hand side of the specular inside the second bend. It's not always possible if they've got a narrow or bendy ear canal. And I've just put some oil in straight away, and I'm just hovering over, and you can see the oils really help to coagulate this. It's coming away in nice pieces. So this is a far easier ear to work with compared to the left because of the consistency of the wax, although this ear is a bit narrower. And this patient attended with their mother, who's got some hearing aids for myself, so they came for their annual service, and they also had some wax. And the patient's mother has got much narrower ears than this patient, and their right ear is actually the more narrow of the two. So although I wouldn't classify this patient having extremely narrow ears, their right ear is far narrower in comparison to the left. So there might be some genetics at play there. There's the eardrum. So I'm just going to mop up some of the surface wax. I'm going to hover over. So this is, I would say, on the cartilage portion. So if you do make contact with the canals, it shouldn't be uncomfortable. It's mainly the inner two-thirds. That doesn't mean that you can be aggressive in the outer third because you can still lacerate the canal wall. So I'm just hovering over everything that comes away. Brilliant. Anything that needs a bit of force. So this is a bit of skin, so I'm just tearing that away. And I'm going to just hover over to the bottom of the canal in a moment. With a bit of soft wax there. And this is the fine end. I think this is a 17 gauge that I'm using. A bit of dead skin involved. And this is right at the entrance now. So on the left, that's the first bend. I'm just working backwards. So all this is actually visible with the naked eye now. I think we can have one final look at the patient's eardrum. I'm just going to dilate that. And it looks nice and healthy. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.